These meetings are hosted by the Gastroenterology Foundation of South Africa in association with Project iEcho, based at the University of New Mexico. And these sessions are held every Wednesday at 4:30, and we have different slots on each Wednesday session. The chat will be open for questions, but afterwards, please feel free to put up your hand and then ask your question. So today we're going to start with a clinical case presented by a fellow from Steve Biko, and then it's going to be followed up by a presentation by Professor Joe Wotameya, and then we will take the questions based on the two presentations. So if everything is okay and everybody's settled in at Badreldin, could you please share your slides, and we're looking forward to your case presentation. Thank you so much.
Can we see my slides now?
Yes, we can see the slides and we can hear you. Please go ahead.
Okay, so this is a short case presentation. This is a 25 years old female patient. She's accountant, diagnosed with ulcerative colitis when she was at the age of 18, and that was in 2015 in February. And she has no personal history or family history of IBD, colon cancer, or any autoimmune disease. She was placed ever since on Asacol, and later on Imuran was added, and she did exceedingly well. Her symptoms resolved and her quality of life improved. But unfortunately, she stopped coming to our clinic, and she was lost to follow-up for up to 4 years. Unfortunately, she presented again to Steve Biko, and that was in February 2021, with worsening diarrhea, abdominal pain, fever, hypertension, and dizzy spells. And a diagnosis of acute severe ulcerative colitis was made. This exactly was 6 years after the diagnosis. She got admitted, and she was treated with intravenous methylprednisolone. She did very well, and in 4 days' time, actually, her condition went back to normal. Then she was discharged home in a very good, stable condition. Late August 2021, she developed first episode non-severe C. diff, and she was treated with oral vancomycin. Again, she was admitted during this episode of diarrhea as well. And she did very well, symptoms-wise. Diarrhea stopped, her appetite improved, and she was discharged fairly home. But she kept coming to the clinic because of diarrhea. That is to say, she was not in clinical remission. And then in December 2021, she was escalated to infliximab due to failure of conventional therapy. And at that time, we got a discussion with her about the use of infliximab, and then she accepted, and then we placed her on infliximab because of failure of conventional therapy, as I mentioned. Then she remained in remission until May 2022, when she presented again with worsening bloody diarrhea. Her disease activity index was 8 out of 12. We did short flexible sigmoidoscopy, and then CMV, C. diff were both ruled out. And this was attributed to immune-mediated drug failure. In fact, at that time, we did serum antibodies for infliximab, as well as trough levels. Trough level came very low. Actually, it was 1.01. And then antibodies were very high, almost 332. And then we decided, we admitted her actually at that time again, and then she was given intravenous methylpred. Her symptoms improved, and we decided to place her on Vido. In August 2022, we started her on Vido, and we continued vedolizumab for 16 months. At first, she reported relief of symptoms during the first 4 months, and her inflammatory markers improved a lot. However, she did not maintain clinical remission, and she didn't achieve clinical remission actually. Her bowel movement continued to fluctuate between 4 times and 5 times, occasionally blood stained. And her disease activity index at that time was 9 out of 12. And then we thought about mechanistic failure of VIDO. Here we did flexible sigmoidoscopy, and it showed severe inflammation of the rectum with erosions, superficial ulcerations, and the mucosa was very friable, even it bleeds untouched, as you can see in the photo. I took biopsies for C. diff, biopsies for CMV. There was no evidence of CMV. We tested again for C. diff. There was no evidence of C. diff. And that is our C-reactive proteins. This exactly it was in December 2023. You can see her C-reactive proteins at first during the period of VIDO. She showed some degree of improvement. So in January 2023, she improved on clinical basis, and then her C-reactive protein dropped to 60 plus, and then late December, when she presented again with these worsening symptoms, her C. diff went up to 112 milligrams per 100 ml. And this actually correlates with endoscopic picture. Then we did fecal calpro. You can see the fecal calpro. This is initially, it was in January 2020. It was like something around 800. Then it dropped to 600 plus. Then again, it dropped further to 500. Then all of a sudden, it went up to 3,512. This was in December 2023, the same time when she presented again, despite being on VIDO for more than 52 weeks. So that is the latest calprotectin, which is 3,500 million micrograms per grams. And at this stage, she was very sick. She was frequent blood diarrhea 3 to 4 times a day with raised inflammatory markers, as you can see. So we decided at this time to switch to another medication, and the choices were between tofacitinib and ustekinumab. Tofa is just non-selective JAK1, JAK3, and lesser extent JAK2 inhibitor, and ustekinumab is IL-23 inhibitor. So in Advico, for example, sometimes we struggle to get some biologics, but this time she was lucky. And then we motivated her for tofa, and then she started tofacitinib. So we started her on tofacitinib, and definitely we screened her for tuberculosis again, and then she got vaccinated for hepatitis B, vaccinated for all other viruses, as well as vaccination against pneumococcal, and then she got the annual vaccine as well. And then she started tofacitinib. We started at first 10 milligrams twice a day for 8 weeks. Then she showed an excellent response. Diarrhea stopped, abdominal pain subsided, and appetite improved. And in fact, I did fecal calprotectin after she got the tofacitinib, and the fecal calprotectin came back at 391 micrograms per gram. So we think that she failed 2 biological therapy, 2 biologic medications, so 2 biological agents, that is infliximab phase due to antibody-mediated drug failure. And later on, she failed VIDO, and then we switched her to this tofacitinib. And she did exceedingly well with tofacitinib. Now the patient, she's doing very fine. She has no diarrhea, she has no abdominal pain, and her hemoglobin raised to more than 10, and then her inflammatory markers also dropped. She's doing fine. So that is the end of my presentation.
Okay, thank you so much for that case. I think there's lots to discuss, but I think let's get to Professor Watermeyer's presentation, and then after that we'll be able to discuss the case and then some of what she says. Jill, over to you. Thank you.
Thanks. Thanks, Matt. I'm just going to try and get it up. Okay. Right, can you see it?
Yep, we can see it. Looking good, thanks.
Okay, perfect. All right, so I thought I would discuss a little bit about JAK inhibitors in IBD, given that this patient responded so very well to tofacitinib. So we all know that the biologics have revolutionized the management of IBD. We have quite a few now that have been approved. Most recently, risankizumab in Crohn's and mirikizumab in ulcerative colitis. But there are drawbacks to the use of monoclonal antibodies. They're high molecular weight proteins, so the human body recognizes them as foreign, which results in the formation of antidrug antibodies, which causes loss of efficacy and obviously immune reactions. They also have very unpredictable pharmacokinetics, and they're influenced by multiple factors such as albumin, body mass index, whether there is severe inflammation. They need to be administered parenterally, either intravenously or subcutaneously. And at best, about 30% of patients will achieve a durable steroid-free remission. So we really need new drugs with new mechanisms of action. So there's some advantages of targeted small molecules which are slowly entering clinical practice. They can be administered orally. They have very predictable pharmacokinetics because they undergo hepatic and renal clearance. These are not biologics, they're drugs. They have a short half-life, so they're eliminated from the body in days, which is of value in the event of a septic complication or the need for surgery. And they're chemical compounds. They're not proteins, so there's no immunogenicity. So one can stop them and start them without being concerned at all about antibody formation. So just a little bit about the JAK-STAT pathway. So the JAKs are a family of 4, JAK1, JAK2, JAK3, and tyrosine kinase. And essentially, as you can see in that figure, an inflammatory cytokine binds to a receptor on the cell surface. This then causes the activation of JAKs, which lie within inside the cell, and subsequently the activation of STATs, which is your signal transducers and activators of transcription. These then move into the nucleus, where they stimulate the production of pro-inflammatory cytokines. Right, so you can see that there are many, many different JAKs, and they typically work either as homodimers, such as JAK2 together with JAK2. That's very important for the erythropoietic and hemopoietic pathways, or they are more commonly heterodimers, such as JAK2 and TYK2, through which interleukin 23 will signal. And you can see the vast number of downstream effects that JAKs cause in terms of the immune system. So the first JAK to be approved in IBD is tofacitinib, which is retailed under the name Xeljanz. It's a non-specific inhibitor. It inhibits JAK1 and JAK3, and at high doses JAK2. It failed to show efficacy in the phase 2 Crohn's disease study, so it was abandoned in the setting of Crohn's. But there have been 3 pivotal phase 3 UC studies, the Octave Induction 1 and 2, and Octave Sustain, which was for 52 weeks. And one can see that the primary endpoint of remission at 8 weeks was significantly higher in both the Octave 1 and Octave 2 studies. When one looks at the maintenance of remission, again, both the 5 milligram and 10 milligram doses of tofacitinib achieved remission significantly more in patients receiving placebo. Tofacitinib was also more effective than placebo in inducing and maintaining mucosal healing, in maintaining corticosteroid-free remission at week 52, in healing the mucosa at week 52, and improving patient quality of life. We also now have longer-term data showing that there's a very durable response with both 5 milligrams and 10 milligram doses of tofacitinib. Some other advantages of tofacitinib: it works very fast. Within 3 days, you can see the separations of the curve. It has a half-life of 3 hours, and it is pretty safe. Okay, so it was approved for the treatment of rheumatoid arthritis in 2012. So there's integrated safety data available for over 6,000 rheumatoid arthritis patients. But we now also have safety data up to 7 years from those Octave clinical trials which have been published. And overall, it doesn't seem to be very many safety signals. But there are just a couple that I would like to mention. The most important is herpes zoster virus reactivation, and the increased rates associated with tofacitinib have been reported in other immune-mediated inflammatory diseases such as rheumatoid arthritis. The risk in UC appears to be about a 2 to 6-fold increase. It's dose dependent, so it's much higher in the 10 milligrams BD dose. Fortunately, it tends to be very mild, usually only 1 or 2 dermatomes, very seldom disseminates, and a number needed to harm of 22 with the 10 milligram BD dose, just to put that in perspective. And there is a recombinant vaccine which is available elsewhere. It's not available in South Africa, unfortunately, which can circumvent this problem. Obviously, the vaccines that we have available in South Africa are live, and so they cannot be used in immunosuppressed patients. Okay, beyond herpes zoster, there really is no overall signal for serious or opportunistic infections. The other issues that have cropped up with this drug is that there is an increase in total cholesterol, LDL and HDL. This has also been seen in rheumatoid arthritis trials. It generally is seen in the first 4 weeks of therapy and then starts to stabilize. But importantly, the HDL and LDL ratios remain unchanged. And this has not been associated with major adverse cardiovascular events. And one can use a statin if you're concerned about this. There's also elevations of creatine kinase which have been reported, but these are minor and reversible, and they're not really associated with clinically important signs or symptoms, and certainly have not been associated with myopathy or rhabdomyolysis. Venothromboembolic disease. So the first concerns about venothromboembolic disease and this class of drugs came from a study called the oral surveillance study, which was performed in rheumatoid arthritis patients. It was a post-marketing study, and it looked at those individuals who were greater than 50 years of age with at least one cardiovascular risk factor, and looked at the safety of tofacitinib compared to anti-TNFs in these patients. And it was found that there was an increased risk of venous thromboembolic disease, and later an increased risk of major adverse cardiovascular events and malignancies. And as a result, the FDA issued a black box warning, which pertains now to all of the drugs in this class, which I'll discuss later. We do have some long-term data in Yousif showing that the serious infections, major adverse cardiovascular events, venous thromboembolic disease, and malignancy are in fact very infrequent. So our population appears to be different from patients with rheumatoid. In the oral surveillance study, they were all over the age of 50. They all had one or more cardiovascular risk factors. So obviously they were going to be at higher risk, particularly for major adverse cardiovascular events. All right, but I think it's still prudent to avoid tofacitinib in patients who have risk factors for VTE or history of VTE, or for that matter, who have any cardiovascular risk factors. Those patients who have a hypercoagulable state, those older patients, those who smoke, immobilization, reduced mobility, recent trauma or surgery, cardiovascular disease, previous cancer, frequent long flights, pilot, for example, hormonal therapy because of the thrombogenicity, and switch to alternative contraception. So what about JAK selectivity? Does it matter? So is there any benefit in increasing JAK selectivity by targeting JAK1 while minimizing JAK2 inhibition? Remember, we don't want to inhibit JAK2 because it's very important for hematopoiesis. And there are now 2 JAK1 selective inhibitors which have been approved. For Badreldin, which is approved in both ulcerative colitis and Crohn's disease, and for filgotinib, which is approved in ulcerative colitis. And I haven't really focused on these. I thought we could discuss them in the discussion time that will follow. So just in summary, tofacitinib is approved for UC, and it's effective in inducing and maintaining steroid-free remission, in healing the mucosa and improving quality of life. It has a very rapid onset of action. It appears to be quite durable over time. It has the advantages of oral dosing, no immunogenicity, and a short half-life. And it does carry the risk of herpes zoster, but this is usually mild. But in the setting of ulcerative colitis, and I'm talking specifically about ulcerative colitis, there are no real other safety signals that have emerged from the long-term data. And obviously, as I've mentioned, there are now 2 new JAK1 selective inhibitors which have been approved. I'm going to end off there.
Fantastic. Thank you, Jill, for that talk on TOFA, covering really all the important aspects and just highlighting how well it works, and obviously the very, very favorable safety profile. I mean, I've got lots of questions to ask, but I don't want to hog the space. In terms of our participants, are there any initial questions of clarity or information that anybody wants to ask? If you do, please post that in the chat or put up your hand. Right, Professor Pomo, thank you so much. Please go ahead.
Sorry, Badreldin, Yousif, The patient you presented, she is 25 now, 25 years of age, and she was diagnosed like 7 to 8 years ago, or almost 10 years ago. Do you know what was the severity of the UC at that time? And do you know if she's completed a family or is she in the process? She married or not? Because
Actually,
that will have an impact on further
for the
management.
first time, 2015, she was diagnosed with with severe colitis, but not acute severe colitis. This is what I found in the file. Just was severe colitis, not acute severe colitis. She is not yet married, and she did complete her family. And the diagnosis was made at BICO based on endoscopy and histology, and she was placed on conventional treatment in 2015.
Yeah, the reason for asking this question is that we're running out of options, and I'm worried that she may end up with colectomy unless her social life is sorted out. She may be in a bad shape in the future.
Actually, now she's getting tougher, and she responded very well to tougher. I don't know if she's going to lose efficacy of tougher in the future or not. But probably if she's going to lose tougher, for example, because I don't have experience actually with tofacitinib, and I don't have even experiences with acute severe colitis or ulcerative colitis much. But if she's going to lose that, then I think the option might be between surgery, which is total colectomy with pouch, or we may go, for example, to advanced combination therapy, because recently I read some articles about the use of combination therapy in patients who fail one or two biologics. And I think there are ongoing trials, the Vega trial for combination therapy of gizilkimab and golimumab. So I have no idea, and maybe Prof. Jill can tell more about advanced combination therapy or surgery, for example, in patients who fail one or two.
So just a couple of comments. You do have another option if she fails tofacitinib. You still have the option of adalimumab. Remember, antibodies to infliximab are not cross-reactive to adalimumab, so there's no reason that adalimumab would not work in her. So that would be your next option if tofa doesn't work. And we're also going to have upadacitinib approved in South Africa very soon. I think it's by the end of this month. So there would be another option there available before you would need to think about colectomy. Advanced combination therapies are still experimental, and I don't think that anybody can afford them in South Africa, that's for sure.
Yeah. The difficulty is that this is a patient who's already defaulted for 4 years. So we may have the options, but if her social life or social background is not sorted out, the education, the mental effect that she may have, we may still, despite the fact that we have those options that are difficult to get, especially in public hospitals, we will still run into problems. That's my point there.
Jill, I just want to follow up on the point on combination therapy, and also just to go one step back. And I'm going to come back to you, Badreldin, about her compliance in general terms, if that was ever a factor in her progression, despite being on adequate therapy. So when she was on Vido, Jill, I know there's a study that says in patients with Crohn's disease, if you add a thiopurine, that might improve the efficacy of the drug. I'm not aware if there are any studies in UC, moderate to severe UC, for combination of Vido with thiopurine. So that's the first question. The second question is that since she showed initial response to Vido, what about dose escalation later on with Vido before giving up on that and saying that it actually doesn't work and changing class altogether?
Yeah, okay, to answer your first question, there's no real evidence that adding a thiopurine will improve the vedolizumab. The reason it improves the efficacy of the anti-TNFs because of the reduction of immunogenicity. I don't think it would be a bad thing to try it, just hoping that there would be some kind of synergism. Yeah, when you're running out of options, you scrape the barrel, don't you? And then the second was dose optimization. Absolutely. You go to maximum doses before you abandon. So I'm not sure if that was the scenario, Yousif, in this case, that you actually used your maximum doses of vedolizumab.
Badreldin, were you able to dose escalate or consider that, or given the constraints financially and resource-wise, was that not even an option?
Actually, she was given a dose of Vido, 300 milligrams 300 milligrams every 8 weeks. And we couldn't make it every 4 weeks because definitely at iEcho, for example, you cannot double the dose in a patient. We have a lot of financial issues. So Jessie was on video, 300 milligrams every 8 weeks. At phase, she responded very well to treatment. I'm not saying very, very well, but she responded to treatment. And she was coming on a regular basis to iEcho to get the medication. So I'm 100% sure of her compliance. And also she was getting Asacol, despite the videos, she was also getting Asacol 2.4 grams every day. But after 6 months of treatment, again, she started to develop like diarrhea, blood, and started to have high inflammatory markers. So we couldn't escalate the dose. And the only option for us at that time was to switch to out of class.
Okay. So going back to her original therapy. So I know Mpo actually asked my question about extent of the disease. Why was she put on Imuran at the outset? Did she have features that suggested that she was going to have likely a very difficult to treat phenotype? That's my first question. And was she compliant on Imuran? Did she also have rectal therapy? So in addition to the per-os Asacol, was she also given topical therapy? So that's the one question. Yeah, maybe, yeah, you can answer that one. If
actually, she was getting the highest dose. She was getting 4.8 grams of Asacol, 1.2 grams every 6 hours. And then they added her Imuran, those weight dose based. Initially, she was getting 50 milligrams, and the dose was increased to 150 milligrams based on her weight. Despite this, she kept on coming to the hospital because of failure to maintain remission or even to induce remission for her. She was getting optimum treatment as far as Asacol and other moon are concerned.
Yeah. Okay. Mpo, I note your hand, but let's hear from Prof. Ali first, and then I'll come back to you, Mpo. Professor Ridwan.
Hi, good afternoon, everybody. Sorry,
Hi,
just in terms, my slant on Professor Homo's question might be that this is a difficult patient, not just because of a failure to respond to therapy, but also a social circumstances in that she defaults. So sorry, Mpo, if I'm misinterpreting your question, but your question might be, is colectomy maybe a salvage therapy in a patient who is difficult both socially and not responding to therapy? Wow, that's a provocative question, Professor Watermeyer.
You're right. That was my question.
So, I mean, having a colectomy is a disaster for a patient who's living in poor social circumstances, having stoma and stoma bags. And then if they do land up getting a pouch, going to the toilet 6 times a day, you have to have a toilet available to go 6 times. And the best you would ever get. I